So, Sir, the Assistant Rajendra is on the way. He is kind of the presentation. In the meantime, all the questions that can be addressed to him, I think he will be willing to answer.
So thank you, Dr. SenGupta, Dr. Sushil, and all my friends sitting here. It is a pleasure to be here again back in the company of all the old timers, I must say. And I've been in South Delhi for a long time. I joined the Escorts in 1992. And then I was there for many years and was visiting Cardiology Hospital, and also we did, because at that time cardiology was not that developed. So the first angioplasty of Jaipur or Rajasthan was done when he was studying there. He used to go in a van. Everything, whole team would go in a van, do the cases and come back. So, and also we started in Cardiology Hospital, and where I was doing every alternate days, etc. So that was very long time back, and Sushil was there and we had a good association. And of course, after that I moved to Max, and now in Vedanta for now more than 10 years. It's 12 years now. And so overall, but still I live here in Saket, so because at that time we moved to Saket recently, and still I go every day to and fro. It takes me about 1 hour. 1 hour going 1 hour. It's good. So we started this program now in Mulchan Hospital, which is like one of my team members is there. I come here only 2 days in a week, in the morning for about 1 hour for local consultation and patient cases. But that is just a little small connection. Overall, I stay the whole day there. But I have been quite happy with working there, because the atmosphere was very nice, and a lot of very well established departments were there. So that is why I moved there. And we could establish new procedures, very new technologies over there. And let me tell you, in India we are able to lead in the field of interventional cardiology in India and also in Asia. We have done the latest procedures, new procedures like transcatheter valve replacements, laser therapies, everything. So every technology is available in Vedanta right now, and we do it very routinely. So that is why we are able to get a lot of fellows for training from all over India, from Delhi, from everywhere. And also, very difficult patients come to us now. Very tough, very difficult to diagnose many times. And of course, then so anyhow, it is quite satisfying to be there in difficult situation, because when you have challenging cases, then it becomes much more interesting for all physicians. So routine cases we do, but challenges are very many over there, and I'm quite happy to share with you now what we are doing. And of course, I think the presentation is there. Okay. So if you have any quick questions or any things, we can talk now. Otherwise, I will be ready in 2 minutes.
Dr. Tulsi sir, if you have questions on the FFR, OCT, etc., etc.
So 1 or 2 questions.
So, Praveen Chandra, pleasure to have you reconnect with you. So, the best treatment for acute attacks is primary angioplasty, transradial, transfemoral, or transbrachial. What do you say?
So these days, as you asked a very nice question, whether it is transradial or transbrachial or transfemoral. So let me tell you, we initially started with transfemoral. All the angioplasty angiography was done transfemoral. But now 80 to 90% of our cases are done transradial. 80-90%. And we are able to discharge every patient, even if it is a complex angioplasty or next. No patient is staying in the hospital beyond 12 hours, 14 hours after angioplasty. because we do transradio. Even if it is an old patient, young patient, patient who has acute MI, everything is transradial now because the ease of movement of the patient is very much. The moment it is done, 2 hours later he can move around, and we are even ready to discharge them the same day. But generally patients don't want to go back the same day. So because when they spend 2-3 lakh rupees, they want some more care in the hospital. That's why. Otherwise they are ready to go.
Sir, next question would be regarding perforations seen in difficult to treat lesions, heavily calcified lesions. It's not working.
Presentation is ready.
आज हमारा प्रॉब्लम है भाई उधर लाना इसको
हाँ चल रहा है।
So finally the presentation is ready, and I'm just going to share with you very briefly. There is not too much of, I won't bore you too much and you will move quickly. So just to try to show you what new has happened in the last 10-15 years. In the last 15 years what we have done and what is the latest right now. So you can see that we started with 3 drugs, cardiology, and I started my training. What was cardiology? It was Lasix, naloxone, Fortflor, and maybe some other sorbitol, etc. For acute MI, streptokinase has just started at that time. And now things have changed. And at that time, now when we talk about the cardiac surgeons, what we were doing for the cardiac surgeons, we were diagnosing the patient, making a diagnosis, mitral stenosis, mitral regurgitation, aortic stenosis, or triple vessel disease, and giving it to the surgeon. So at that time, surgery was the main treatment. Surgeon was the king of cardiology. But fortunately or unfortunately, things have changed now. Now most of the things are managed by cardiology. Complex angioplasties, doing interventions in cardiogenic shock. Now we are able to treat patients who come in very sick condition. So today, that is the problem with us also, that we get patients from all over, like from neighboring cities, from Delhi, everywhere, who are very sick because they are low BP. Nobody is wanting to handle these patients. They are sometimes ventilator, they are sometimes BP of 70 systolic, 80 systolic. So we get them, but we get them little late. So that is why we are not talking to everybody. If you have to make a decision, make it quick. If somebody is going to cardiogenic shock, make the patient move quicker. Because if that time slot is gone, and now we have new parameters to check patients, you will be surprised. We do CT scans now for patients. We now assess CT scans. Earlier we only knew how to do ECG, echo, and angiography. But CT scan is a new tool which we do every day. Earlier it was done by radiologists only, but we assess the CT scans now to make a decision whether what kind of valve we have to treat and how do we do this. So we have leadless pacemakers, of course you must have heard about this, and then changing the valve in post-surgical patients, taking up very sick patients, all is now possible. And so we have moved from the heart, to the whole body. And now today, cardiologist has now become a cardiovascular specialist. So we do the entire vascular system. Somebody has a leakage of the vessels, burst of the vessels, or blockage of the iliac arteries, or brachial, everything is now being managed by interventional cardiologists. So we do, these advances in PCI have led to this new approach of complete revascularization. Now we can treat multiple blockages by angioplasty routinely. There is no discussion now, too much of discussion. We discharge them quickly. The stenosis rates, restenosis rates have gone down, and you will be surprised now to hear that 50% of my angioplasty today is stentless, no stents. We have new techniques to treat these patients, like doing laser, doing a drug-eluting balloon, no stent inside. So 3 months later, the artery is natural. So we do that these days, and of course, as Dr. JPS has asked this question about which route, 90% is radial route. Radial route, next day patient goes home. So we have to move them faster. Of course, that is required both because more the patient stays, more he pays. The second is the hospitals are so busy these days, we want to move the patients quicker from the beds, so the new patients are admitted, and of course, it's better to go home faster. Then we have more predictable short-term and long-term outcomes, better quality and quality of life we can give to these patients. And I was talking about high-risk patients, so early invasive therapy in cardiogenic shock, using intra-aortic balloon pump, using Impella system. We have an Impella system, it is very expensive right now. So let me just tell you that if we have a patient who has multiple vessel disease, he has low cardiac output, going into cardiogenic shock, low BP, 90 systolic, what do? We have a system, we can put them on Impella, which is a cardiac pump, which goes inside the heart. We did use it in, for many years now, but now it is much more available, more experience have come in, and the only problem is it is very expensive, right? So many times patients come to us that whatever it costs, please do that. So these are the patients where we use this Impella system, which costs about 20 lakhs. If we do an angioplasty, it is additional 20 lakhs for the Impella system. Disposable, finish. But the patient survives. So every week, every 10 days we do a Impella case like this, will come from many places with such. But the only thing which I am going to share with you is, if you have a patient like this, move them faster. Because up till now we had this concept that let us this patient stabilize and then we will work on it. But if the time doesn't give you that kind of window, the patient will not stabilize, and if he stabilizes a little bit, his pH is going up, and we have new parameters to check with this based on the blood gases we do in these patients. And if we find that his the blood gas parameters are going wrong, he has to be moved faster. Even if his BP is 90 systolic, 100 systolic. Do not keep them on inotropes. Inotropes are, we have recognized that inotropes are the biggest killer in cardiogenic shock. Up till now what we were doing, BP is going to low, give norepinephrine infusion, give dopamine infusion, and let me tell you, if a patient who is on 2 inotropes for more than 6 hours and his urine output is declining, this patient is a dead man. He is a dead patient for you. You will keep treating him for the next few hours, next day or so, he is not going to make it. So you have to take the decision as soon as you see that his parameters are going down. And that is the time to react. If you don't react in time, it's not going to make it. So that is my advice. So we started with single vessel disease treatment, putting 1 stent, then 2 stents. Now we can see almost everything is now possible. And the last thing which I am showing here is that doing angioplasty without stent is another thing which we have now developed. And we do almost 50% cases without stent implantation. Or even if there are multiple blockages, 4 blockages, we put 1 stent. All the 3 rest, no stents. Because stents have a problem. They are stenosis. They have a problem. There is thrombus formation, stent thrombosis. And stent thrombosis is a very bad disease. It can kill. So this new concept is coming where we do stent less angioplasty. When doing FFR, IVAS and OCT, I told you already, I think many of you must have attended my the CMEs on FFR. We started 10, 11 years back. Now it is, we do it very routinely because this decreases the number of stents. Then using IVAS and OCTs have made the procedure very predictable. We are very happy to discharge the patient next day, because we know that the patient is going to be fine. So we make sure during that procedure itself that the result should be absolutely perfect. It takes 10 minutes more, takes much more technology to use, and we can check everything, recheck everything, and then only we shift the patient out of the catheter. So this is something which we do on a very routine basis. Of course, CT angio, you all know that we do CT angios for patients where there is suspicion of coronary artery disease. And then we still do it. It is a very good technique to do it. Then knowing about PET scan, which is another test which we do these days for cardiac patients. It's not only for cancer. Very routinely, almost every day I get a PET scan done for my patients. Because these are the patients where heart attack has happened. Okay? and the ejection fraction is come to 25%. Angiography shows one single blockage. So earlier system was put a stent inside, do angioplasty. No, we don't do angioplasty in these patients. First you do a viability scan, which is a PET scan. In PET scan, it shows whether by putting a stent he is going to benefit or not. So then only you go ahead and do it. Because many times you must have seen patient underwent angioplasty, still his ejection fraction is 35%. So what is the fun in doing it? Okay. So that is why even if somebody has a blockage, and if his heart is damaged, there is no need to do angioplasty or bypass or anything. Just medicine, medical therapy. So that is something which we do. And of course, the technologies which we are using these days are, shock waves, which is intravascular lithotripsy for calcified lesion. I think somebody was asking that. Cutting balloons, laser, rotablation, all this we do very routinely. So these are the instruments which we use these days. So this one is the laser, which is, I think, nobody is using it in Delhi at least. In Gurgaon, of course, nobody is using it. So very few centers, but we use it almost every day. We use lasers for very difficult cases. Where the balloon is not going, stent is not going, we use laser to make a passage to put a stent inside. So laser therapy, then rotablation, and of course cutting balloon, shock wave. Shock wave is another very good thing which we are using for very hard lesions. Whereas we put a balloon, give shock waves, and suddenly it becomes absolutely soft. It is the same shock wave which we use for renal stone, renal stone. But this is a micro laser, micro lithotripsy. It is a very small catheter which goes inside the coronary artery, which is 2.0 millimeter in diameter, which goes inside and gives shocks. So it gives 10 shocks at one time. And the patient can hear the shocks in the brain. So when we give shocks, he says, oh, something is ticking inside the brain. So 10 shocks, 10 times it is ticking in the brain. So that is the shock wave therapy. And for the radial, as I showed you, we are very easily managing it with the bands. New bands have come. Manual compression is not required anymore because after femoral angioplasty, earlier it was compression. The patient was having pain, bleeding. Now we have these new devices to take care of that. In post bypass patients, again we can do now graft angioplasty very effectively. This is just one of the examples showing that we can now give stent-like results without young patient, 33-year-old patient, we came to us with this blockage. You see, this blockage I think is not working, but this blockage which was here in this artery, 90%, everybody would put a stent, but he is 33 years old. If I put a stent today, he is going to have the stent for the whole life. And then the stent can also have its own problems after a few years. So why don't we keep it natural? So here in these cases we do drug-eluting balloon, which is stent-like results. And of course this technique is now very, increasingly we are using in many patients, especially young patients, 33, 34, 35, and this is the impella pump. You see, this is the pump inside the heart and angioplasty is being done. So the pump is working in association with the heart, which means it is like a true pump. The pump, submersible pump. It's a submersible pump inside the ventricle. It sucks blood from the heart, injects it to the ventricle. And the liter is 2.5 liters per minute. Okay? So this is a 2.5 liter pump. We also have a 3.5 liter. So we can use either of them. And then of course, we have the hybrid surgery cath lab, which is again a very, very important thing, which is very helpful when we do all our cases of valves. And that is why, like touchwood, we have no valve infection in last 500 cases of TAVI. No valve infection. Because we do it in the hybrid cath lab routine. No way we are not, even if we have to wait for a day, we will wait. Because that is the norm which we follow, so that everything becomes very safe. This is the microsurgery which we do. It is a minimally invasive surgery from the side and put a stent on the other hand. So this is a combination. This is known as hybrid procedure. So we have done this. This was a patient who had triple vessel disease, and what he has undergone is surgery from the side out and stent from the arteries. So this is a combination which we do in this hybrid cath lab. This cath lab is very unique, which where we do both the things together. Surgery and angioplasty together at the same time. This is known as the hybrid cath lab. So in CAD treatment, we have so many options today. New drugs, new imaging techniques, new FFR techniques, and PELA, drug-eluting balloons, everything. So it is really helping. Structures of the heart are mitral valve, aortic valve, tricuspid valve, pulmonary valve, LA appendage. These are the structures of the heart. So today we are able to treat all this through intervention and no surgery is required. As you can see here, surgery is to be done earlier. Not anymore. Anybody who is high risk, advanced age, more than 60 years, we do valve replacement through TAVI procedure where there is no surgery involved. It is transfemoral, as you are seeing here. It is just a small hole inside the femoral artery. And sometimes not even the femoral artery, the carotid artery, subclavian artery. So this is the comparison of surgery versus TAVI procedure. And first day, the patient is in the ward. So second day discharge. Now we discharge all patients of our valve replacement second day. So although we can discharge the next day also, but as I said, once they spend 20 lakh rupees, they want at least 2 days in the hospital. So, but we are ready to discharge them the next day because it is so predictable now. And these are the kind of patients we do, 60, 70 years, 80 years, obese patients, elderly patients, octogenarians, everybody can be done now. And some of the patients have previous valve surgery. In these patients we can do the second time, if the valve is failing, we can do without surgery. And just 3 days back, we did a procedure where we replaced 2 valves at the same time, mitral and aortic, without surgery. So this was the combined procedure. And of course, very difficult cases also we do, like horizontal anatomies, bicuspid aortic valves, heavily calcified valves, everything we can now approach and do. And this is the CT scan, which I was telling you. These are the images which we look at now. So this is how we decide. How do we go, what size we do, everything is pre-decided. It is not that during the procedure we are trying to see what we are doing. Everything is pre-decided. And this is the way it happens, you see. This is the valve which is done through the femoral approach, and here we are trying to expand the valve is being positioned, okay? So, so this is the valve. This is how it is implanted inside the body. And once it is implanted, you can see it starts functioning immediately. There is no stitch, no cut, nothing. Sometimes we do it with the transcarotid. This is the patient who came from, I think, GK or somewhere. Everything was occluded. The artery was totally occluded. How do we go inside? So we went from, this was an 80-year-old lady. She is still there. And we did about the inside 8-9 years back. So transcarotid approach. From the carotid arteries, we put the valve inside. So this is the small cut through. And through that, we take the sheath inside. And we are doing this. Okay. So this is how the valve is being positioned. This is how the valve is positioned through the tube. Okay. And this is how it looks after that. So this technique has really, kind of evolved now for many years. We started this about 10 years back, and we do it from all kind of approaches. Subclavian, this is the subclavian approach from the subclavian artery. This artery was blocked, this artery was blocked. We went from the subclavian artery. Put the valve inside. You see, the valve has been positioned inside. So for aortic valve, now it is one of the standard methods of doing this treatment. For mitral valve also, we do this, and this is one of the first patients which we did many years back. This lady was very elderly, post-MBR, very sick, and every time she was getting admitted 3 months. So we did the mitral valve replacement, and this is the mitral valve where we do this procedure again through the same balloon, same valve. So basically, for the valves, where surgery has been done earlier. Again, it is a very easy thing to do, which we do now. See the previous valve, and then we put the second valve inside. This is the second valve which we are putting inside. See? This is how we are putting the second valve inside. Valve and valve. So the second surgery is not required, especially after the age of 60 years, 70 years, 80 years. So on a daily basis, we take these kind of decisions. We then close these holes inside the heart to the, and this is the 3D T which we do, 3-dimensional T. So basically, you know, in various kind of situations where previous valve rings have been put, we do now valve replacements through the transcutaneous approach. Do septal dilatations, put the valve inside the ring, and generally it works out. These are the kind of valves which we are using. Various kind of tissue valves. These are all tissue valves. And the last thing which I am going to show you is the mitral clip. This is again a very interesting thing. When the valve is leaking, then we do this mitral clip procedure. Here you can see that the clip is this leaking valve. We will put this clip. This is the clip which stays inside. Small clip in the leaking valve. And then of course we bring the procedure. Of course this is the procedures you know already. ASD closure is a routine. LAA closure is the last thing which I am going to show is for prevention of stroke, which we are doing. Again, very unique in our institution. We do a lot of these procedures, and these are the patients where in the LA appendage we put this umbrella inside. And this is for those patients who have stroke, recurrent stroke, or those patients of atrial fibrillation who cannot tolerate anticoagulation therapy, or who cannot, they start bleeding. So in these patients we put this device, because after this they need not take any anticoagulation. Then in many complicated cases of post-surgical failures, where you know leakages from the side, all this thing we are now able to kind of repair and replace, and so it's kind of a repair thing which we do in our labs. So more complex things are coming, and of course we have to develop all these techniques. Then the holistic approach which we now take for all these patients. We have to treat the whole patient, not just small people. And of course using the complex devices like impella, shockwave, PVL, everything, it's like quite a. So with this was a small capsule which I wanted to share with you. Thank you very much. And it's been a very interesting journey.
Sir, can you
Can
have a seat and a drink, sir? Be with us.
So,
Light
dear colleagues and friends,
There.
you must admit it's been a masterly presentation from one of the masters, and it's been the magnificent developments which have been seen in the field of interventional cardiology, in which sir has been one of the pioneers. And yes, it comes at a cost, but then we should have a take-home message from here that the oft-repeated thing which we see in patients that उन्होंने तो angioplasty ज़बरदस्ती कर दिया, that is not there. It is the onus is on to you to convince the patient to know everything has a reason, has a reason and a rationale behind it, which is fully justified as and when the procedure is done. And like sir mentioned earlier with the FFR sir, and now with the PETs that you do, the PET CTs which you do to see the viability of the myocardium, etc. Angioplasties have been, have to be rationalized in any patient, any sick patient. Also with the marvelous procedures for valve replacements, etc. And all kinds of, I presume that even for a ruptured aortic aneurysm, right now you do a stenting of sorts only rather than rushing the patient to the OT. So likewise for multiple things, and this marvelous procedure for putting in a device, the umbrella device in the left atrial appendage for patients with atrial fibrillation who have coagulation problem. So all these things, yes, admittedly they come at a cost, but they improve the quality of life to such a phenomenal extent that anybody who can get it done has to be offered this alternative. And I can just say that sir is one of the best persons to do it. And any questions, any clarifications or any inputs, I think I'll just hand it over to sir. Thank you.
The mic, please. You must have one mic. Working parent? So, Dr. Praveen Chandra, what a mastery talk, as Dr. SenGupta said, we learned a lot. So, just a case regarding Jack, he published a case about a year back, and a 62-year-old male who had a CTO and PCI was done to the LED, had a perforation which evolved into life-threatening cardiac tamponade, had a hemodynamic collapse with a blood pressure of 60/40, with malignant ventricular arrhythmias. 5 coils were needed to seal the fissure perforated segments. So he talked about the IVL. So this seems to be a game changer in the way you treat heavily calcified lesions in the coronary. Sir, a word on the IVL.
IVL is a very effective technique for treating very heavily calcified hard lesions, and it takes about 5 minutes to do this. So it is not a problem at all, and there is hardly any complications with IVL. It has less complications and very effective.
So how do you decide between a rotablation to be done or?
So rotablation was the earlier technique which we were using, but rotablation had its own problems. That you have to set up the whole thing, etc. And then sometimes rotablation could lead to complications like perforation, as he said already. And in this, the chance of perforation is very high. So, and bigger arteries can go.
So as you said correctly, it's the safest, most predictable and effective way to treat calcifications to optimize stent placement as well. So rotablators probably have taken a back seat now ever since the IVL has come, but it comes in a steeper price. So it's a disposable catheter that you use. So how much does it cost, sir?
Yeah, the cost of IVL is about 3 lakhs for the IVL itself. So generally the cost of angioplasty in our institution is about 2.5 to 3 lakhs. So to the patient generally it comes to about 6 lakhs or so if we use IVL.
Right.
So it is expensive, but
but it's worth it.
Like for example, I did a case just now, and that's why I got little late. There was an 80-year-old man, 83-year-old man, father of a physician, and he had a bypass surgery done 6 months back. He came with acute coronary syndrome, and he was admitted in some hospital in Noida, and then did LVF last night. So then he, thinking that it is a very complex thing, they moved the patient here, and then we did the angio, very calcified here. And the graft had occluded, 2 of the graft has occluded. So we said, okay, we have to do something. And in this case, you have to use the IVL. So we use the IVL, put stents inside, patient stabilize, and most likely, if everything goes well, he will discharge tomorrow. So that is the beauty of this IVL.
Sir, April 2022, ACC at Orlando published some game-changing and practice-changing trials. Were you there? Okay. So they talked about the complete trial, which is the complete revascularization of both the culprit as well as the non-culprit vessels, improves quality of life and it decreased mortality as well. So it's a winner. What do you say, sir, regarding the complete revascularization trial, both culprit and non-culprit vessels to be targeted?
Right. So we see according to the patient condition, patient's blockages, then we decide whether we do it all at the same time or we do it after 2 days or after 1 month. We take that decision based on many factors. But certainly the plan is to do a complete revascularization at least for that patient, but not at the same time always. Yeah? Okay.
Great. Sir, the Pac-Man AMI.
Sir, just a small, the case that you mentioned about the doctor's father within a bypass which was done 6 months back, who has now got this. So, you said that grafts were occluded. So, what extra needs to be done with respect to the, because obviously there's something which is more thrombogenic in this system.
So in these cases now, as you all know, that there is a new treatment which has come for prevention of new thrombus formation in patients who have chronic coronary artery disease. And that is the use of a newer anticoagulant which is known as rivaroxaban. Which I'm very happy with the results because there is no stent thrombosis. patient doesn't need to take dual antiplatelet therapy for more than 1 month or 2 months. There is no need.
So
It's okay.
drugs action will be there for 3 months?
No, for 3 months the healing is happening, the drug is there. And after that the healing is done, then no need to have the drug, no need to have the stent.
The drug is there for 2 months.
So it is like a dissolvable suture.
Yes, yes.
What drug-eluting stents have no role now? Drug-eluting stents?
They have role, but we try to do it as much as possible with the drug-eluting balloon these days, because our feeling is that the stent should not be inside the body. Simple. And the other thing, which I was telling you about the cardiogenic shock thing, and Dr. Sushil Chauhan's thing, the primary angioplasty, the acute angioplasty which was done on him, is the only angioplasty which has saved lives. Otherwise, every angioplasty which is done is not saving life, it is only improving quality of life. And that was year 1995. When I came back from my training from France, I was in sports only. And then there was a new concept of acute MI angioplasty. So there was nothing existing here. So I did the first acute MI angioplasty of escorts also, because it was done in the night time. And I was sitting in the campus, right?
Yeah.
So I was the only one who was able to know how to open the cath lab, how to start the cath lab, and also get the technician and the nurses.
In the red building.
In the red building. So I used to do that for everybody's patients, because I was junior most of that time. But I was doing the primary angioplasty, I started the program at that time. And it has really helped in many people like this. And the final thing which I want to tell you now is the magic figure. So everybody sitting here, if you have a patient of cardiogenic shock, what you should know? I told you about the inotrope. As soon as you're going for the second inotrope, shift the patient to a facility where it can be treated. Number 1. Number 2, look at the blood gas report. And what will you see in the blood gas report?
Alkalosis or
You have to look at the lactate levels. Okay? If the lactate level is going more than 2, and if it is more than 2, you have to shift the patient. If it is more than 4, shift the patient now. And if it is more than 6 per hours, don't shift the patient. Patient is a dead patient. Even if the patient is talking, he is going to die in the next few hours. So lactate is the magic figure. 2, 4 and 6. So at 2, start thinking immediately within 1 hour. At 4, move now. And at 6, stop. Okay?
Sir, Dr. S.P. Singh has a question.
Sir, I am Dr. S.P. Singh. Sir, I am a patient of cardiac failure.
Oh boy.
For last 3 years. From where my journey started, just I wanted to say everybody.
Yes.
Just here.
Very good.
Sir, in 1905, I was sleeping and wake up at 5 o'clock.
1905?
1905?
No, can't be 1905.
2005, sir.
2000.
Very sweating. I am going to go to ECG, reflecting something. So somebody said, go to G1 hospital. I had a TMT. It was positive 3.5 minutes. Again, after exercising heavily for 1 month, then again I went to there. It was 2.5 minutes. So I have consulted one of my friend, Dr. D. Batra. Sir, you know, sir. He told me, "Yeah, कोई बात नहीं, Dr. Chandra साहब के पास चलते हैं." That time it was escort hospital. You were there. So मैं आपसे मिला, सर. आपने क्या एडमिट हो जाइए और हम आपकी एंजियोग्राफी करते हैं, सर. आपने एंजियोग्राफी की. जो एंजियोग्राफी कर रहे थे वो सीट लगा रहा था. मैंने भैया यू आर नॉट ए डॉक्टर चंद्रा. नहीं, इमीडिएटली आप आ गए. तो मैंने आपको पहचान लिया. तो आप सर ऐसे नहीं थे सर, बड़े हैंडसम. सोच नहीं सकता आप चंद्रा है. आप कोई नहीं पहचान सकता आपको. मैं देखा यार डॉक्टर चंद्रा आज ये है, वो नहीं है. स्मार्ट है सर. आप 2005 में मैं सोच ही नहीं सकता सर. इतनी बात है।
आपने कहानी का
Nobody can- कोई बात नहीं, कोई बात नहीं, सर। लेकिन जो भी एंजियोग्राफी आपने की, आपने कहा डॉक्टर साहब आपके एंजियोग्राफी में कहीं कहीं कुछ भी नहीं है, नॉर्मल है। तो मैं यही कहना सकता हूँ उस वक्त नॉर्मल थी सर, फिर मैंने 5 साल फिर कराई नॉर्मल थी, फिर कराई नॉर्मल थी, फिर कराई नॉर्मल थी। लेकिन आज मैं इस एज पर पहुँच गया हूँ, वो यही कहता कि यार आपका तो गिने चुने दिन रह गए आपके। सर मैंने 5 साल काट दिए कहते कहते, गिने चुनते रह गए। 2017 में मेरे को रिकॉर्ड किया था कि यू आर ए हाइपरट्रोफिक कार्डियोमायोपैथी पेशेंट और आपके टाइम देना चुना है। लेकिन सर आई एम persistently since then I am 20 ejective fraction of 60, today still 60. सर मेरे बारे में कुछ बताइए, कितना चलूंगा नहीं चलूंगा।
आपकी आवाज इतनी तेजी से आ रही है इसके
सर मेरी एंजियोग्राफी की जाती है, मेरी आर्टरी है ही नहीं सर राइट।
नहीं, मेरी डायग्नोसिस
सर मेरी राइट अपोजिट आर्टरी है ही नहीं, मैं एक ही लेफ्ट में चल रहा हूँ सर।
You are going to live more than 50 years.
राइट अपोजिट आर्टरी है ही नहीं, कोई कहता ही नहीं।
सर इम्पोर्टेड गाड़ियाँ लेफ्ट हैंड ड्राइवर होती है, तो लेफ्ट से चल रहा है।
ये अपोजिट आर्टरी राइट है ही नहीं मेरी सर।
My best wishes to you always. I'm sure you will do very well. All the best to you.
I think
सर ये कैंडिडेट है क्या?
we'll give the last question to Dr. Please just concentrate.
सर थैंक यू, बहुत अच्छा लगा इतने दिन से, सर बहुत दिनों से नहीं देखा आपको, एंड वेलकम बैक टू साउथ दिल्ली। सर अभी आपने कहा कि लेजर्स हम यूज कर रहे हैं, तो क्या ये हम अपेक्षा कर रहे हैं कि जैसे हम PUR करते हैं प्रोस्टेट में, ये आगे जाने वाला ऐसे ही होने वाला है कि भाई अगर आपको कोई एंजियोप्लास्टी करनी है तो आप एक डॉक्टर साहब के पास जाइए और वहाँ पर आप लेजर करके और आप सवेरे जाइए और शाम को वापस आइए। इट इज गोइंग टू हैपन लाइक दैट?
It is exactly happening like this. For example, just yesterday only, there is a patient who was also a doctor. Unfortunately, I get a lot of doctors. So he was a doctor. He had angioplasty done few months back, and he had a serious blockage again in the same stent. I said no more stent. We did a laser, intracranial balloon, discharged the stent.
So that means कि सर सॉरी मैं हिंदी में बोल रहा हूँ सर, मैं बेसिकली हिंदी भाषी हूँ, मेरे फॉलोअर्स हिंदी में। मेरा क्वेश्चन है सर कि अगर आपके पास राजू श्रीवास्तव अभी जिनकी अभी डेथ हो गई है, अगर वो आपके पास आते तो आप उनको लेजर टेक्निक से इलाज करते?
देखो चक्कर ये है कि राजू श्रीवास्तव का टाइम से टाइम इज द मोस्ट ही रीच्ड एम्स।
नहीं सर मैं उसमें बात नहीं कर रहा हूँ, देखिए वो तो एक्सीडेंट था
टाइम से
नहीं मैं कह रहा हूँ कि अगर वो पहले मान लीजिए
लेजर से,
अगर वो आपके पास आते तो लेजर से अगर हम ट्रीटमेंट करते क्या वो बच सकता था?
मे बी व्हाई नॉट, ऑफ कोर्स
मींस पॉसिबिलिटी थी कि वो बच सकते थे। सो दैट मींस
What does laser got to do here?
But why he had undergone angioplasty?
There's an old cardiac
He had
patient.
undergone twice.
Yes.
7 steps.
Abrupt closure he had. Other coronary. What does laser got to do?
I think friends, really honestly, we had a wonderful session with Dr. Praveen Chandra sir and Dr. S SenGupta.